Hello, I'm David Cohen from St. Francis Hospital and the Cardiovascular Research Foundation. Thank you for joining us. We're here at TCT Asia Pacific on the final day of the meeting, which has been a wonderful meeting. And I'm joined by my good friend, Dr. Eberhard Grube. You will notice that we have the same uniforms, which is appropriate. Then we have three wonderful panelists. We have Dr. Philippe Garot from Paris. We have Jung-Min from Asan Medical Center here in Korea, and we have Nicolas van Mieghem from Erasmus Medical Center in Rotterdam. So welcome, gentlemen.
Thank you.
So the topic today is TAVR. Nobody knows anything about TAVR. So we have many different things we can discuss, and we just came from a really great session where we talked about some of these issues, but some of them not so much. So the motivation for this discussion is clearly that TAVR continues to grow. In the United States, several years ago, TAVR surpassed surgical AVR. I don't know, is TAVR the most common form of aortic valve replacement in France right now?
Yeah.
Korea?
Yeah.
Since 2021.
Okay.
Can I just quickly step in, because there's a big difference between TAVR US and TAVR Europe, if I may say, particularly with respect to age. In the United States, the age is falling. In Europe, it's relatively stable in the 80s. So there's a big difference between them. In the French registry, we're still dealing with patients in the 80s, as opposed to United States.
Yeah, I don't know. I mean, the mean age still in the U.S. is in the high 70s, but there are plenty of patients being treated below 70, that's for sure. And so we will talk about that a little bit just down the line. And I think, despite the fact that TAVR has now, again, surpassed surgery, it continues to grow, it continues to iterate. We are continuing to have new valves, new versions of our valves, new adjunctive procedures like embolic protection, different ways of pacing. All sorts of things are continuing to modify with the procedure. And as you told us, Nicolas, in the session, the types of procedures we're doing. We're facing an oncoming tsunami of TAV and TAV that we need to be prepared for. So all of these things will be changing. So what I want to first start out with is for our panelists, a simple question for each of you. What do you think are the most important issues in TAVR for the next decade? What are the questions we have most? What are the most important procedural factors or device-related factors? What do you think, Philippe?
Well, I think it's a tough question, but definitely the most important for the future is about THV durability and lifetime management. I think as we are treating, as you said, more and more younger people with longer life expectancy, we need to have options for the future. And what we heard in this meeting and what we know from literature is that the first intervention is crucial to have good results in the future, because the first intervention is the one that gives you options for the future, depending on the type of valve, depending the implant depth, or the commissural alignment, for example. So we have a lot of parameters guiding for future options.
That's a great point. Is the first valve is the foundation for the future, and you can open options or you can close options.
Yeah.
Jung-Min?
Yeah, in the same context, I think that the first valve failure, how to deal with the failure of the TAVR valve is another important issue. In my centers, we did 1,800. I found the number of failed TAVR and then re-TAVR cases, only 18 cases, but the TAVR number is rapidly growing. So I think re-TAVR cases are rapidly growing in the future. So we don't know how to deal with it, but in the future we have to focus on how to deal with the failed TAVR cases.
It's clearly going to be a big issue. Nicolas, you agree?
Yeah, completely agree. This is the dawn of a new era. This is the era of failing transcatheter valves as well. And we are not experts at this point in time. So we need to learn a lot about what should be the focus in a revalving procedure and how to plan those procedures. And as we discussed today, we are considering these CT-derived simulations that might help us and that offer us very visual representations of what to expect with a valve-in-valve or even a valve-in-valve in-valve procedure.
Yeah, I thought, you showed a figure during your talk about the layers.
Yeah.
And it is very sobering to see the number of, even with a second valve in valve, the number of layers that you're dealing with, a third, and they're on both sides, right? So it's not
yeah.
just, you had 4 layers on one side, you have 4 on the other. It's, I mean, and you showed how the area gets progressively narrower.
Yeah, so we anticipate that with the first valve procedure, your valve area will decline by approximately 5 to 10%. With the second one, it's 20%. With the third one, it's at least 30%. So you enter the prosthesis patient mismatch discussion again, but then for every patient.
Yeah. So I think we have, and we'll come back to this issue because I want to explore that very much more.
Can I just add one thing quickly?
Always one thing.
Yeah, no, because we're talking about layers.
Yeah.
We're not talking about the material that led to degeneration, which could be pannus, which could be calcification, which could be thrombus. That has to be added to the layers.
Yeah.
Because some are compressible, some are not.
No,
Yeah,
I think
this is a very important issue. So even in the surgical valve failure, we have some experience that we published data. So there is some pannus. So second valve, definitely there are huge remaining pressure gradient. So we found that the valve type is very important. So self-expanding valve, they can maintain the bigger effective orifice area. And location is very important. The shallow implantation, make sure the good effective orifice area, but once implanted the valve in the deep and huge remaining the pressure gradient.
right. So it's, I mean, again, I think it's, we've come a long way since the early days when we were just very happy to get the patient in the room and out of the room alive. Now we have to think about how are we going to keep them alive for 20 years or 30 years. So it's, that's how old I am. I remember those days for that. So let's switch to some individual questions I want to target to each of our panelists in areas of your own expertise. So Jung-Min, you gave a beautiful talk on bicuspid aortic valve disease, which is very common, much more common in Asia than it is in Western countries. And I really want to probe on that a little bit. You have worked out some very nice algorithms for how you treat bicuspid aortic valve disease, your valve selection, all of those different things. But tell me a little bit about your thoughts about the young patients. And what is the best thing for the young patients? And maybe you'd start out by telling me what is young.
Yes. First of all, we have to define what is young. But in my sense, the younger than 7 years old is young, I think. So the second thing is that the bicuspid is not a single disease. Bicuspid aortic valve disease is a spectrum of diseases, so associated with many other things, orthopathy, and some bicuspid aortic valve is a small calcification, but big calcification. Location of calcium is very different. So individual cases are so different, the bicuspid features. So I believe that the patient age is very old, more than 80. TAVR is good. But the young patient, I'd like recommend to the patient the surgical AVR first.
So under 70, you said?
Yeah.
Perhaps.
So, but the particular case, very low calcification, I assume that the low procedural risk, I can do the TAVR for the bicuspid aortic valve, but be cautious because currently data, there is no difference regarding hard endpoint, death and stroke, but there is a little bit higher, numerically higher risk of pacemaker implantation, and always the bicuspid TAVR is associated with the risk of aortic valve injury. So be careful for the TAVR for bicuspid aortic valve disease.
I mean, it's definitely a tougher procedure, the planning. What is your practice in the Netherlands these days with respect to patient comes in, to see you? They heard Dr. Van Mieghem, he's the master of TAVR, and they, would really like a TAVR. They're 70 years old with a bicuspid valve. How are you having that discussion?
Well, it starts with an holistic approach, and we do need a CT scan to come with a formal answer. The CT will tell us about the possibility of a safe TAVI procedure, because there are, for instance, bicuspid phenotypes that you should not be targeting with a TAVI procedure. But oftentimes the patients are very well educated these days, right? They have
read your
they
papers,
have been doing
your...
their Google works, and they know what a TAVI is, and they also know how basically successful a procedure is from a patient perspective, because they have a short, they look in the short term. They want to go home as soon as possible, the young patients. They want to resume their activities, their daily activities. And it is up to us to determine whether we can do a safe TAVI procedure, but also preserve the perspectives for the future. And this is, I think, an important discussion that we need to have with our surgical colleagues, but also we need to include the patient in the discussion. So this really is a shared decision making.
When you have that discussion with your patients, do you find them receptive to the idea of, yes, we can do this now, but we need to think a little longer than the now?
Well, not always, but most of the time, I can have a strong preference, but the patient also has a preference. And as long as it's technically doable, I think we also need to respect what the patient wants.
It is a balance for sure.
It is.
There are some cases where you have to say, like, this is simply not feasible. It's not safe. I won't do it. Maybe somebody down the street might, but I think it's a mistake to do that. Philippe, is that similar in your center?
Yeah, completely similar. I mean, the patient willing is very important. We only consider data, literature, and statistics, but you have to consider what the patient has in mind. And I remember not so far ago, a patient I had with bicuspid aortic valve, and he was more or less a friend, and he was young, he was less than 70. He went to surgery and he had a lot of complications. So I don't want to say that surgery is complication, but because we know that we can have that in both arms. But typically, then I thought, okay, I refrained from proposing the TAVI because he was young and because he was a friend. And then, okay. So I think we have to think about everything.
That's important, right? It should become a joint discussion, a joint consensus. But we're also no longer the almighty physician, right? It's not because we feel that it should happen. The patient also needs to be receptive.
No, the patient is always, the center of the heart team has to be the patient.
Exactly.
They're the one who's being, who's going to have the greatest consequence of the whole thing.
Everything that you said is on everybody's slide. We have to take patient into consideration. At the end of the day, maybe it's locally different, geographically different, but as far as Germany is concerned, it is still a patient-physician relationship. The patient wants the easiest, the best, and the shortest. And we respect this, but at the end of the day, we don't, because we look at something beyond what he feels he should be doing. And I had a beautiful example. My tax accountant had a severe aortic stenosis. The local hospital said, we can go both ways, but we would suggest surgery because of. And it is very, very difficult. Once the patient has been primed, to get him away from that thought. He follows the advice of the patient. So yes, we should respect it, but we should also take into account that the patient has his own thoughts about it without having medical knowledge.
I think we have, it's an important educational process, and the truth is we don't have a lot of long-term data on treating bicuspid aortic stenosis, and especially what happens when that first valve fails, which, if we're talking about treating patients under the age of 70, they're all going to fail, at least based on what we have now. Let me switch gears for a minute, and we'll ask Philippe specifically about halt and valve thrombosis. It's an issue it's kind of a nagging issue. It's not at the top of our mind, but it's always there. We saw some data, on it today from one of the Japanese colleagues. Do you think that, if that prevention of halt right now is a priority? Do you think and what might change that in the future? What information do we really most need, I guess I would say?
Well, again, it's not an easy way of thinking about the future with TAVI, because halt, we don't really know the frequency, we don't really know the significance, we don't really know how preventing halt is good for the future. What we know is that, yes, halt might be a first step to valve degeneration. So really preventing halt is something that is good for the future.
Potentially. I
Potentially.
mean, we don't even know that
No.
entirely.
No.
I mean, certainly right now, we have therapies that prevent halt, right? We have anticoagulants and they
Yeah.
work, but they also have side effects that are undesirable. And so I think that's why we're in this conundrum.
And it's funny because our Japanese colleagues, they also presented data from the Ocean TAVI registry, where they already made a suggestion, but do we need antiplatelet drugs? Why we could do without any kind of antithrombotic therapy.
Certainly,
and
we haven't
that
studied it.
contradicts obviously with this concept of halt,
Yeah.
because we are getting concerned about halt for the future, and I think this is where we may need more research to figure out whether to figure out whether a NOAC, a non-vitamin K antagonist, might suffice in preventing this CT diagnosis of halt, but at the same time doesn't come with an excess of bleeding.
Right.
And I think so far the trials have not been well enough designed to answer that
I
question.
mean, they
because-
certainly haven't, again, they've shown trade-offs, right? We have trade-offs.
Well, but they always combine some kind of antiplatelet
I
drug
see.
on top of
Which is maybe a mistake,
NOACs, and
yeah.
that is not what you need
Any
to do.
thoughts on, from your perspective, the surgeons, when they started the bioprosthetic valve implants, they put the patient routinely, unless there's a high risk, on anticoagulation. Would that be an option?
I mean, it's been tried. It's, again, it prevents thrombosis, right? You guys did the...
Yeah, actually, we did a randomized trial to compare the NOAC using edoxaban versus the antiplatelet treatment. Definitely, NOAC treatment is associated with low risk of valvular thrombosis, but even though it's not associated with clinical endpoint.
So far, yeah, I think that really is the question we still need to answer: is does, early valve thrombosis predispose to late degeneration?
Yeah.
If that's the case, then we have a more profound, and stronger indication that we need to do something. Is anybody screening for valve thrombosis with CT at any time point?
Not systematically.
No.
We also ran a trial, it's called the Redox trial, where we looked into single therapy with a NOAC in patients with no indication for oral anticoagulant drug therapy, and looked at halt. So those patients got systematically a follow-up CT at 3 to 6 months. And yes, it works. It works. But the question is, do you want to expose your patients to systematic CT follow-ups?
Right.
And because there is also a risk related
Yeah,
to
I think that I mean, the problem is, again, this issue of a lot of it is silent, a lot of it gets better.
Yeah.
It comes and goes because maybe there's a role we'd say, okay, at 3 months everybody gets a CT, and if you have halt, you get 6 months of an anticoagulant, and try something like that with a screening test. So not everybody indiscriminately is getting an anticoagulant, but these to me are still very relevant questions.
But the moment we see an increase in gradients, that will trigger us. And
Yeah.
then the first next step is going to be a CT scan.
right, and that at that point it's clinical. It's
Yeah.
it is manifest.
It's maybe too late. I mean,
It might be.
for some patients, if you have something like valve under expansion or valve-in-valve procedures, maybe you have to think about systematic CT for these patients because the risk of halt is higher.
No, for sure there are. I think we have a lot to learn there. Let me, in the last 2 minutes that we have, go back to this topic of TAV and TAV, the next epidemic that we're going to be facing. What percentage? So we heard from Jung-Min that a very small percentage of TAV and TAV. What is the percentage of TAV and TAV in France right now? Do you know?
It's about 1%.
Very low. And Nicolas?
Something similar. I think
Okay.
TAV and SAV is up to 10% of my practice.
Right, okay.
And then, TAV
So it
in-
still is just a very,
Yeah.
a minuscule thing.
Yeah.
So I think for the audience, you gave a wonderful talk about just sort of, and I think the CT is obviously the key. So tell us how you, in 2024, when you have a patient, you're thinking about TAV and TAV, what are the things that you focus on? What are the tools you rely on the most?
Well, basically it starts with the first procedure, right? So the index TAVI procedure. We want to know what was the anatomy when we start off.
So you want to actually see the
Oh
original
yeah,
CT?
yeah.
if
We
you
always
can.
go back to the first CT. Then we obviously do a follow-up CT. So once the valve needs treatment, we will do another CT, and then we can confirm the exact position of the valve relative to the coronaries, what is the actual depth of implantation, because you cannot determine that well enough by fluoroscopy. And then also try to understand the mechanism. So do you see a lot of calcifications on the leaflets? That it plays a role. And then obviously we are exploring this, the concept of simulations. So we leverage the CT-derived simulations to get a better understanding of the coronaries and also future coronary accessibility.
I mean, that seems like, a no-brainer here. I mean, I think we, at a minimum, doing our own evaluation, but I think this is an area where the CT, the simulations, the artificial intelligence can play an enormous role, I believe. I mean, so, and what systems do you have experience with so far?
So we are using or collaborating with FEOPS and with Materialize. Yeah.
And I mean, how good are they?
Oh, well, they are. It's still early in the game, because we also discussed in the panel that you want to learn more about device-host interactions. Basically, also what Eberhard alluded to. You want to know, is it pannus, is it calcium? What is happening with those leaflets, because they will affect your result of the revalving procedure. They're not quite there yet. At this point, they give us very good visuals on the relative positioning to the coronaries.
Right.
They also give us, obviously, information on commissural alignment, and they give us an idea of this neoskirt. Those are all very
the
relevant.
neoskirt is very critical, and it's something you really can't judge well by any other technique, I think. And it has a lot to do with where you implant a second valve, whether a second valve is safe at all to do so. I think that is so, so critical. I see we are out of time. Eberhard is my timekeeper. He's pointing to the red screen, so I think apparently I could go on for hours. But I think I want to thank all of you for really a wonderful discussion. I think there's so much to learn still, which is what makes interventional cardiology and structural cardiology so exciting. I hope I'll have a chance to revisit this over the next couple of years and see where the next issues will be. I want to thank all of you for joining us, and have a great day.
Thank you.
Thank you.